Okay, so I will talk about evidence, risks, and misconceptions on COVID-19 epidemiology. Starting with some disclosures, I have no conflicts of interest, financial or other. I possess no personal Facebook, Twitter, or other social media accounts, and I have not signed any petitions, declarations, or memoranda. This may sound like a weird disclosure statement, but I think nowadays that's what it needs to look like. Some preemptive comments. Dealing with a pandemic, one needs to use epidemiology. A pandemic is an epidemic, you need epidemiology, that's for sure, but you also need crisis management, you need mathematical sociology, you need psychology of behavior, you need psychiatry, systems research, data sciences, statistics, operational research, health policy, health economics, behavioral economics, decision analysis, health services research. My goodness, I forgot infectious diseases, virology, management. You need all of that. In an acute and urgent setting, evidence can be scant. It can be of low quality or even fully misleading, and therefore models and speculations are called in to fill in the gaps. The success of this endeavor, filling in the gaps with models and speculations, can be very questionable because speculative models can be even more misleading. Worse, pandemic waves are not static. They come and go. They rise, they continue, they peak, and then they disappear sometimes, or they continue with some low activity. So this makes perfect, secure causal inference almost impossible. So we're struggling against the odds to make some statements about something that is not static. What is the current status of the pandemic as of today? We have 110 million documented cases globally. We have a bit over 2.4 million deaths with COVID-19. This is about 0.03% of the global population has died with that stamp of a diagnosis. Probably, in fact, we have approximately 1.5 to 2 billion total cases globally. If you look at the hundreds of seroprevalence studies that have been done and you try to extrapolate across the global population, that's 20%, maybe 25% even of the global population has been infected, with great variability across locations. The global population infection fatality rate is probably in the range of 0.12 to 0.15. It's clearly higher in North America, Europe, and Latin America. It is clearly lower in Asia and probably even lower in Africa. It has substantial variability across locations, settings, and populations. Approximately 0.5% of the global population has been fully vaccinated, and approximately 2% has received one vaccine dose. Vaccines are an amazing development, but unfortunately, it's impossible so far to deploy them as fast as we would wish. I hope we could have done better in that regard. What we have learned about COVID-19 epidemiology is that it has astonishingly strong risk stratification. If you look at the age distribution of deaths during the first wave, for example, this is a paper we published very early in the pandemic, the majority of deaths in epicenters in Europe has been in people who are over 80 years old. If you look at the deaths that occur in people less than 40 years old in Europe, it has been in the range of 1% with some variability across locations. It's a bit higher in the US, and it's very different if you go to India or Mexico that have very young populations, and you do anticipate that a larger share of the fatalities would be in younger age groups. But the age risk stratification is really amazing. If you compare the death risk of people over 65 versus those who are less than 65, in European countries, it has been in the range of 50 to 100-fold different. In the US, it has been a little bit lower, but still very, very strong. If you compare a 10-year-old versus an 80-year-old, the risk stratification, we're talking of something in the range of 1,000-fold or perhaps even more. This has been seen in multiple studies. This is shown graphically in the open safety data from the UK, both for men and for women. Men are doing a bit more poorly, but the strongest effect is really the age gradient. If you look at the non-elderly, and of course you can define that in different ways, but let's say if we look at people less than 65, it doesn't mean that people over 65 are elderly. Some of them are younger than me. If you look at these data and you try to translate what was the absolute risk of death in people less than 65 in pandemic epicenters during the first wave, as expressed in vehicle miles per day equivalents, to get a sense of what is the absolute risk roughly like, it's roughly in the range of commuter traffic in many of these locations. It's much higher in epicenters in the US. For example, The worst is in New York and New Jersey, where the equivalent would be the risk not of an average commuter by car, but of a truck driver who has to drive from Manhattan to Washington, D.C. and back. And there are people who do that for a job, actually. Conversely, the risk is extremely high as you go to people who have underlying diseases and are also older. However, if you go in the other direction, not just less than 65, but also people who do not have underlying diseases, the proportion of deaths that occur in such individuals is really very, very low, a very small percentage of the total mortality burden. If you look at other risk factors, we have many other risk factors that have been very clearly delineated. So we are in a very unique situation, which is not so common in epidemiology, that we can stratify risk extremely well compared to many other fields where after decades of work, we still have very little predictive ability to tell who's going to do poorly and who's going to do well. If you take these data across the entire population, this is a typical population of a European country like France, or also a country like the US. This is what it looks like in terms of who are the people who are at high risk. We have a very thin slice of nursing home residents who are at tremendous risk. The infection fatality rate in these people is about 25%. 1 out of 4 of them who are infected will die. And we have these other thin slices of thick color who are people who are at different age groups, but nevertheless, they have other comorbidities that are posing them at high risk. If you add these thin slices, they are about 10% of the population in a typical country like France. However, they would account for 80, 90, or even more than 90% of the fatalities in many locations. Have things changed in the second wave compared to the first wave? We recently published this paper where we looked at the age distribution and fatalities in nursing homes in European countries and US and wherever data were available for the age distribution in the second wave versus the first wave. And we don't really see much of a difference. If anything, we see that in many countries, the proportion of deaths that are accounted by people who are young, for example, in the stratum less than 50 years old, is diminishing. It's not increasing, it's going down. If we also look at the proportion of deaths that are accounted by nursing home residents, in most countries, with few exceptions, it has gone down substantially. Of course, there are some reporting delays, and this may affect some of these results. However, I think that this is a clear trend. Does it mean that we're doing a better job in protecting nursing homes? That might be one explanation. Another possibility might be that, unfortunately, we have had so many nursing homes infected already so massively that a very large share of these nursing homes, especially the most susceptible ones, have already been devastated. There's exceptions here. There's Australia that clearly had a very successful management in the first wave. In the second wave, they had a number of nursing home residents who died that was not happening in the first wave. The infection fatality rates are very important because they can give us a sense of what we should expect in terms of policy planning and what is the expected total burden of that pandemic in terms of fatalities and burden of disease if we cannot control it. I'm not saying that we should not control it. We should do our best to control it, but it's important to know how lethal this infection is. And these are the data that I put together in a paper that was published several months ago in the bulletin of the WHO, looking across 51 different locations around the world. As you see, there's substantial heterogeneity, which is largely explained by age strata that are different in different countries, by the presence of different shares of the population who are residing in nursing homes, and they're very frail and packed together in these environments, management of the pandemic, and other factors. If you look across 82 studies in 51 locations, the median infection fatality rate is 0.23%. The range obviously is much larger, from 0 to 1.31%. If you look among people less than 70 years old, the median is 0.05, with a range of 0 to 0.31. Locations with overall low mortality rates below the global average have a median IFR of 0.09%. So, places like Africa, places like India, places probably the majority of places around the world have very low infection fatality rate. Others have higher, and if you go to the locations that were the ones that were most hard hit, the ones that did not avoid massacres in nursing homes and had very large fatality rates in elderly populations. The median infection fatality rate is 0.57%. So in some cases, it's even higher than that, as I will show you. For example, UK and Spain, probably it's even higher than 0.57. What have we learned then? The infection fatality rate can vary a lot. It can vary from 1/5 of influenza to 10 times that of influenza, again, with some uncertainty about what the infection fatality rate of a typical season influenza is, because we don't really measure influenza one case at a time. We have some very broad epidemiological surveillance, and we try to make some very broad inferences. The infection fatality rate is not a constant. It's not like the gravitational constant or the Km of an enzyme. It's not physics or chemistry. It is highly dependent on case mix, on population structure, on who is infected, on how people are treated, and many, many other factors. But the good news is that since we know most of these important factors now, we can make the infection fatality rate much lower if we manage to avoid massacres in settings and in populations that really carry the large burden of fatalities. Here's some examples of very effective protection of vulnerable groups and examples of very poor protection of vulnerable groups. You take Singapore, which is a city-state with very high population density, so you would expect that you would have a precarious situation with the virus spreading very widely. There have been about 60,000 documented cases, probably more than 100,000, because no matter how intensive testing is done, it's likely that a lot of cases are missed. Only 29 deaths, of which only 3 in nursing homes. The infection fatality rate is less than 0.03%. It's probably less than 0.02%, maybe even 0.01%. Here's the counterexample. Vulnerable groups actually not protected at all, but even more frequently infected than other people. The first wave in Spain, Belgium, and UK had 63%, 61%, and 44% of COVID-19 deaths in nursing home residents. France also had a very high burden of fatalities in nursing homes. Nursing home residents, actually, based on what we know, had 2 to 3-fold higher risk of infection than other people in the general community. So in a way, we protected those who had less need to be protected far more than those who had very high need to be protected. Given these massacres, the infection fatality rate in these locations reached or exceeded 1% in the first wave. Can we achieve precision shielding? This is the topic that I discussed in a paper in BMJ Global Health that was published last month. I'm proposing some metrics of assessment and feasibility of deployment. And why is that important? Well, if you remember, in the last 10 years, we have heard a lot about precision medicine and precision health. In a way, precision medicine, precision health was supposed to replace everything that we were doing in medicine. Instead of treating average patients, we would be treating very precisely each person with what is best for them. And we were trying to do that, I have to say, mostly unsuccessfully, including my own work, with relative risks of 1.3 or even 1.03. For example, for people working in genetics and genomics, where I've done some of my past research, it's very typical to come up with risk factors that have relative risks of 1.03, and you try to develop precision medicine out of them. In COVID-19, we have relative risks of over 1,000. So can we make it work with relative risk of over 1,000? If we cannot make it work with relative risks of more than 1,000, I think we should just quit the business of medicine and public health. I mean, if that cannot work, then the whole notion that epidemiology can be helpful, we're not really helpful discipline, to be honest. So are we achieving effective shielding, like the example that I showed you with Singapore or Taiwan or South Korea, or inverse protection? Are we protecting those who are less in need of protection and leaving those who need to be protected unprotected? You can calculate how much protection we're achieving, and this is what I do in that precision shielding paper. These are some formulas that I derive for looking at the ratio of deaths in 2 risk groups and giving you a sense of the relative protection in these groups. You can do the same for nursing home residents if you use some different equations, and this is what it looks like. If you look at the very bottom of the slide, if you take a look at India, S, which is the precision shielding is 1, it means no precision shielding, no big surprise. You know, India, people are packed together, very dense population, especially in slums. it's impossible to protect anyone. So young, old, they're pretty much infected at an equal rate. China did a very poor job. They had higher rates of infection in the elderly population compared to the young population. US did a modestly good job, less than 1, but not really that great. Places like Iceland and Denmark did much better. Even the UK managed to protect the elderly in the first wave to some extent. However, they did very poorly when it comes to protecting nursing homes. As I showed you, Belgium, Spain, UK, they have very high shielding ratios. It means that their nursing homes were infected far more frequently compared to general population, as opposed to places like South Korea that has a shielding ratio of 0.07 in nursing homes. It means that nursing home residents in South Korea were infected 15 times less compared to the general population. This is why it was a major factor that they had such low fatalities. Israel also did very well. Slovenia did well in the first wave. They didn't do well at all in the second wave. Germany did pretty well in the first wave. They're doing modestly well in the second wave, not that great as the first wave. And Denmark also did pretty well. A major problem dealing with COVID-19 is that it is invisible. That's a major handicap on trying to deal with it. This is a paper where we tried to model the implications of having an invisible pandemic. We did that work with Ellen Kuhl and her team from mechanical engineering at Stanford, and we came up with this SEISIAR model, trying to take into account transmission from symptomatic people and from asymptomatic or pre-symptomatic or oligosymptomatic, or people who just were not detected. They were not documented as infection because they either had no symptoms or they had symptoms that they didn't ask for testing, so they remain uninfected. And these are the majority. They were the huge majority early in the pandemic. They continue to be the majority, even though we have more testing nowadays. The implications of the pandemic being largely invisible is that you have this division across the scientific community on how to deal with it. It's very difficult to deal with an invisible enemy. So the first school of thought is, goodness, this is horrible. We need to treat everyone as if they're infected. We need to stop all exposures. We need to freeze everything. We just need to wait until vaccination. Just freeze anything and we're dying. That's all we need to do. The problem with that is that you can never stop all exposures. Freezing means that you still have about half the population, actually disadvantaged people, homeless, refugees, people who are poor, people who are essential workers who need to work. If they don't work, they will lose their jobs. If they don't work, we will starve. I'm giving Zoom lectures while they're working and exposing themselves, but I depend on them. So we cannot really stop all exposures. We have people who are massively exposed in mass transportation. We have people who are massively exposed in their work environments where they still have to work. And in a way, we are protecting people like me who don't need to be protected, and we're leaving those people who are often having a worse profile of risk factors and therefore at a higher risk to be exposed. Many aggressive measures really protect the least vulnerable and leave more exposed the most vulnerable. Another example is nursing homes. If you have lockdown, this does absolutely nothing for nursing homes on its own, unless you aggressively test personnel and staff, unless you have draconian measures of hygiene. And we know that many nursing homes actually do not have that. They have quite the opposite. They're places that the standard of living is not really that great. It's a little bit like knowing that you have a serial killer who has declared that I'm going to kill that specific person, the nursing home in this case, and instead of having an effort to protect that person where the serial killer has said, I'm going to kill that person, you just have more policemen placed randomly around the country in random locations, or you give lectures and political speeches to the congregations about how important it is to love each other. This is what lockdown does. It's not really doing what it is supposed to do. So the second school of thought is test everyone or as many as you can and isolate those who are infected. And then the issue is, do we have the means to isolate those who are infected, especially those who are disadvantaged? How are we going to isolate people who are homeless, people who are at best at shelters where they're more massively infected? The third school of thought perform rigorous epidemiological surveillance. This is something that I have been saying from the beginning. We need representative, rigorous data to see where the pandemic is, how it is advancing. Unfortunately, we have depended just on collecting data from PCR tests that are very haphazard. Test as many as you can, protect with draconian measures the most vulnerable, decrease exposures with reasonable non-disruptive measures, and have the best possible management of infected people along with vaccination, and hope that vaccination can be deployed pretty rapidly, which unfortunately it is not so far. Can we see which of the interventions that we have used have created the best results? Of course, this is the holy grail, and hundreds of scientists have tried to do that. Unfortunately, it's not easy. The pandemic waves, as I said, they're not static. They come and go, they rise, they peak, they have exponential phases, sigmoid phases. Eventually, they fit very well into Gompertz functions, as my colleague at Stanford, Mike Levitt, has shown. And if you try to model multiple interventions that are superimposed on each other in very tight sequence, much of what you get will depend on what kind of model you apply. This is one example. On the top panels, these are the models applied by Imperial College team, an amazingly competent team with great methodologists and great modelists. They try to see whether different measures, including lockdown, had an impact on the pandemic, and their conclusion was that of all the measures, it was lockdown that made the biggest difference. However, Imperial College itself, the very same team, had used a completely different model, and they had published data with that model applied to states in the US rather than European countries. So we applied their own model to the European countries that they published in their Nature paper, and this is what you get in the bottom panel. In that case, that second model shows that lockdown had no benefit. So the very same team produces a model and publishes a model, huge benefit, but it also has another model that shows no benefit. And actually, if you look at the fit of these models based on various Bayesian model fit parameters, model 2 has a much better fit to the data, practically in all countries with very rare exceptions. It seems to represent reality much better. Not only that, the Nature paper included only some European countries, but left out some other European countries where data were available, and where if you applied either model 1 or model 2, you would see no benefit from lockdown. So practically what you see here is selective reporting. And we've seen that even with some of the best teams in the past. We see that again in the case of the COVID-19 pandemic measures literature. Mobility. Mobility is something else that you can model. And of course, mobility is very important. Whenever you apply different measures, you see a change in mobility, and this seems to be good news. People are very happy that people are not moving around. But in fact, which mobility are we talking about? We need to differentiate between blindly suppressed mobility, purposefully suppressed mobility, reduction of exposure, reduction of high-risk exposure, and reduction of exposure of high-risk people. These are very different things. One is a surrogate of the other. It's like a babushka doll that you need to open all the iterations of the doll until you get to what you really need. And what you really need may be very different compared to what many of the measures do for lockdown, which is just blindly suppressing mobility without thinking, who am I suppressing and why am I suppressing and what am I doing for those who really need to avoid high-risk exposures because they are at high risk. This is the team that my work did, trying to assess the effect of more restrictive lockdown measures as opposed to less restrictive measures. We did our best. We tried to avoid selective reporting. We got all the data that we could from countries that had eligible information. We tried to use a standardized approach. We use a difference in difference and a counterfactual approach to try to have as good control as possible in the evaluation. And this is how it looks like. If you ask, did any of the measures that we took, any of the measures, including any sort of social distancing, any sort of any intervention, not just draconian lockdown, yes, it did. I mean, it seems that the growth rate went down. Now, can I tell you how much of that would have happened even if the viral pandemic wave had been allowed to run its course? I don't. I cannot say that, and I'm not recommending that we should just leave things unopposed. So whatever the population did have a diminishing effect on the growth rate of case studies. And this is the combined effect that you can see. There was some impact in practically all countries other than Spain that didn't seem to have much of an impact. However, if you look at a comparison of Sweden and South Korea as counterfactuals against 8 countries that had more restrictive, what we call draconian lockdown measures, really there was no benefit. Actually, the confidence intervals for that draconian lockdown add-on exclude the possibility of a 30% reduction in cases. And in most cases, they even exclude the possibility of 15% reduction in case growth. In fact, most of the estimates are in the wrong direction. Most of the estimates suggest that draconian lockdown, if anything, increased the problem. It made things worse. It was pro-contagion. And based on what I told you already, this probably does make sense because we protected people who had less need to be protected, and we allowed those who were at higher risk of exposure and at higher risk also of an adverse outcome. Can we ever get that sorted out with randomized trials? I have proposed that for quite a while. This is a paper we published quite a while ago now, along with Ioannidis and Floriano Det, suggesting that we should do randomized trials of COVID-19 social distancing interventions. How many randomized trials have we done or have we registered for COVID-19 when it comes to things like treatments? 2,758 is my latest count. We have a database, COVID evidence, that my colleague Lars Hemkins and my team are keeping alive. How many trials have we done on social distancing interventions? Very, very few. There are some. There are some that have been done on education and on gym opening, and there's also a trial done in Denmark on masks that had a very rough time to be published because it didn't really show a result that people wanted to see. But I think we need more such trials, and we can think of trials that are feasible. It doesn't have to be the perfect trials. We can think of testing different interventions and their dosing, the timing and the duration of implementation, the sequencing, the combination, the type of enforcement of adherence that we're trying to achieve, the weaning process, the measurements of extent of adoption, the use of response indicators and surrogates, what kind of target groups we want to go for in settings. And there are lots of things that we can measure. We are currently measuring just PCR documented infections, and yes, that's okay. Hospitalizations, ICU makes more sense. We capture those data as well. Death, of course, but there's always that concern about how many of these deaths are translating to lots of person years lost versus deaths that would have happened pretty soon anyhow. Timing of the measurements, data collection outcomes, long-term relevance, cost effectiveness, placing in context, all of these are issues that need to be taken into account if we really want to get out of this mess and have some more reliable evidence. In the absence of definitive evidence, governments are just responding at random. I think that they just respond mostly by mimicry. They say, what did that government next door do? What did the country next to us do? Oh, they shut down everything? Oh, we should shut down everything. We are under pressure. The politicians are always under pressure because they have the opposition parties as well that are going to tell them that you didn't do a good job, you didn't close everything, you didn't destroy everything. You should have destroyed everything to save us from this virus. So there's a lot of mimicry. There's very little evidence and a lot of mimicry in how responses to the pandemic are happening, unfortunately. And I think some of them are clearly devastating. For example, when it comes to school closures, there's lots of papers now that say that we have very little benefit in terms of saving people's lives. And actually, we're killing many people directly and indirectly. For example, there's that paper by Dimitri Christakis' team estimating more than 5 million lost person years from closed schools in the US in the first wave. Do I believe that number? I think it's probably exaggerated if you take a look at the modeling. But even if it's 10 times less, it's really an amazing loss, and it's really devastating. And I think that there's no benefit to counter even a small fraction of such a loss. In fact, we have a lot of evidence now that there's a lot of excess deaths currently happening, and even worse, to happen in the future if we continue with aggressive measures. This is just a partial list that I put together several months ago in a paper in the European Journal of Clinical Investigation. We have documented that people with acute myocardial infarction and other acute diseases were not given proper hospital care. People were afraid to go to the hospital, and hospitals reduced admissions, afraid of overload. So that resulted in reverting back to the early 20th century in terms of dealing with diseases that we could have dealt very well with excellent outcomes. These people just died unhelped by our health system. People with cancer having delayed treatment, maybe we're not seeing these deaths right away, but we will be seeing them in the next several years. Disrupted cancer prevention, inability to offer cancer prevention services under aggressive measures. I have been on the skeptical side about some of these prevention services in the past, but I have to say some of them do work, and we will see their impact of loss of that prevention effort in the next 20 years. Other healthcare disruption with postponement or cancellation of elective procedures and regular care. Mental health disruption leading to violence, domestic suicide, homicide. At a global level, starvation is a major concern. We've seen lockdowns leading to disruption of food production and transport, and this is really a major concern because we have millions of people who die of starvation every year. We've had more than 100, perhaps 200 more million people globally who entered in the zone of threat from starvation because of the lockdown measures just within a few months. Tuberculosis. There's disruption of tuberculosis management programs. Tuberculosis is killing about 1.5 million people every year. There's estimates that in the next 5 years, we'll have an extra 1.4 million deaths because of the disruption that lockdown and the pandemic caused. These are mostly young and middle-aged people. They're not 80, 85 years old. Childhood diseases with disruption of vaccination programs, diseases that we had eliminated practically or suppressed to a very high degree may come back. Alcohol, other diseases of despair from mental health disruption and from unemployment. We've seen that happen in many countries, especially in the Eastern Bloc in the past when they collapsed. We had major problems from diseases of despair. Multiple chronic diseases from unemployment, lack of health insurance and poverty. Some countries that don't have universal insurance will be at an even worse position, but even those who have universal insurance, I think, will be hard-pressed under the circumstances to see how they maintain their healthcare facilities and structures and services. And eventually, we may see collapse of the healthcare system, which we try to protect, and in much worse ways, in much more durable ways compared to the acute wave that we try to take care of. Can we predict what will happen? Honestly, we cannot. I cannot tell you what this fall is going to look like, because if we go back in 2019 or 2018 or 2017, if you ask me, how will the influenza look like this winter? I could probably not tell you very much. We would be tracking what is happening and what's happening in the Southern Hemisphere, for example, but every year is very difficult to predict. In fact, with COVID-19, we've realized that we cannot predict even what will happen tomorrow. These are 4 models by amazing teams. So the University of Washington, IHME, Los Alamos, University of Texas, and YYJ. If you see blue or not red color, it means that even for next day prediction, the performance is horrible. So the performance is practically horrible across the board. If you look at the uncertainty of these models, which means that you don't just make a prediction, but you also have a boundary about the uncertainty surrounding that estimate, well, it's a little better, but some of these boundaries are so large that go from 0 to 1,000, and therefore they're not really very useful. And still, you have very poor performance. Even the boundaries cannot capture what will happen the next day, let alone what will happen next season or next year. Why are models so poor? Should we just give up? Should we just say, forget about prediction. We've had enough. We've published 100,000 papers. They're all junk. Let's throw them away. Well, not really. Some of these papers may be useful. We can do a bit better, but we have to face our enemies. We have to face our demons. We have to face the problems. What are these problems? Poor data input on key features of the pandemic that go into theory-based forecasting. We've had tons of SIR models that are informed by very precariously wrong data. Poor data input for database forecasting, for example, time series. Wrong assumptions in the modeling. High sensitivity of the estimates. Lack of incorporation of epidemiological features. I told you that we have very strong epidemiology. Most models completely ignore that. The fact that we have that 1,000-fold difference in risks, you should model that and see how you should avoid people dying who are at the very high risk strata, but we don't do that most of the time. poor past evidence on the effects of the available interventions. We have been struggling with data as the ones that I showed you, but in fact, we do have prior pandemics. Yes, that's true. We have 1918, for example, that was about 100-fold or 1,000-fold worse. Okay, let's try to extrapolate from that. That's 100 years old data. And you can imagine how bad the quality of this data would be trying to extrapolate to a coronavirus that has a very, very different profile compared to 1918. 1918 Spanish flu killed people who were on average 28 years old at the age of death, compared to 80 years old for COVID-19. Lack of transparency, errors, just plain errors. Some of these models are very complex. I've seen errors in my own modeling, trying to do my best. So I'm not trying to accuse anyone. They're very difficult to avoid. Lack of determinacy, looking at only one or a few dimensions of the problem at hand. That's probably the worst. As I showed you, there's many aspects in public health. Currently, we're just focusing on one of them, but we have many other problems that are getting worse by some of the interventions and some of the measures that we're taking. Lack of expertise in crucial disciplines. You cannot take care of these additional problems unless you have expertise across the board to cover all of these problems and how they should be modeled, how we should try to predict them, how we should try to do something about them. Groupthink and bandwagon effects, terrible during the COVID-19 pandemic. It has become much worse under political pressure. The intermingling of politics and science has been completely horrible. How can we get rid of that? I think that we need to defend science. We need to defend scientific independence. We need to defend people who think out of the box. We need to defend people who take high risks. It's fine to be wrong, but you need to be independent thinker and be able to look very carefully at data and avoid groupthink and bandwagon effects. And finally, selective reporting. If you believe that something is true, you would report just whatever fits to your narrative. And I think we have seen a lot of that happening, unfortunately, and much of that has implications for the measures that are being promoted. Can we at least predict what would be the total fatalities when this thing is over, when the pandemic is done? Yes, we could do that. We can assume, for example, that if we don't manage to contain the pandemic, we will have 60% of the global population infected. We can use what we know about infection fatality rates, for example, 25% infection fatality rate in the institutionalized frail elderly, and much higher in older people compared to younger people. And if you run the calculations, you end up with 8.76 million over 5 years. Now, hopefully, we will not get there if we do something that works. So if we manage to keep it at 30% at a global level, that would mean 4.38 million. And if we manage to protect those who are at high risk more than those who are at low risk, we can even get it lower. Unfortunately, as I showed you, so far we have not been doing that. So, we've missed the boat for numbers like 1.58 or 1.76 million, which would have assumed that we really protect those who need to be protected. We have just thrown them under the bus, and we have protected the young people and children who have very minimal risk instead. Additional factors that may affect the total death toll from the COVID-19 pandemic. Vaccines are the big unknown. They're an amazing development, but we need just to make sure that they become available, that they're also effective in the community as they are in phase 3 trials, that they're safe. So far, they look fine. Uptake, how quickly we can deploy them, how well we can cover high-risk populations, what is the impact on transmission, on duration of protection. All of that are unknown questions at the moment, but I'm optimistic that vaccines will make a difference, will make an impact. Development and use of effective treatments and management options and avoidance of detrimental ones. We have a very active research agenda on that front, but progress has been modest so far. The impact of economic and social disruption in the course and management of the pandemic, the public health and personal hygiene measures that we can implement in a way that we do not disrupt the rest of our world. The interplay with other emerging health problems. For example, we have worried a lot about influenza hitting at the same time. Influenza seems to have disappeared while COVID is acting. But other infections like tuberculosis, as I mentioned, could be very influential on the total burden of fatalities for other reasons. Also, we need to worry about the diseases that are induced or worsened by the epidemic response. Reinfection, I will show you some data about that. Chronic disease consequences from COVID-19, long-term morbidity, and the worst, catastrophic chaotic events. For example, wars, riots, revolutions, and other social meltdown that unfortunately some of the aggressive measures, especially as they become long-term, might be incentivizing, and that could really be chaotic. Reinfection. We have some data that seem promising so far. Obviously, I cannot tell you about reinfection risk 5 years from now, but I can tell you about reinfection risk within 7 to 9 months. These are data that we recently published with colleagues from Austria, looking at the entire population in the country. The odds ratio was 0.09 for the second wave versus the first wave. So people who were infected in the first wave, they had 91% decreased risk of getting infected compared to those who didn't have documented infection. So that looks like very good news. And none of these reinfections actually resulted in a COVID-19 death. So it's also possible that even those reinfections are leading to less severe disease, but obviously we need to collect far more information to be able to be certain about that. And finally, vaccines. I will close with that. As I said, they're an amazing achievement, but I'm worrying that the cavalry is arriving too late, at least this year, but they will be available at least for next season, and that may change things dramatically. In the meanwhile, we have to be a bit cautious about risk compensation, meaning if people who get vaccinated, they start increasing their risk exposures, even more so in the window that they're not protected. Recently, I did a modeling analysis trying to see how big of an impact that could have, and it could have an impact, especially if the vaccines end up not being as effective as they seem to be in phase 3 trials with 95% efficacy. If the effectiveness is less, risk compensation could be a major problem if effectiveness is 60% or even 80%. Bottom line, what should we do? What should work? I think that intense early testing combined with contact tracing in the early phase before the epidemic wave established itself, examples, Singapore, Taiwan, has been very successful. I think it's good to do this again to pick and abort any resurgence. Massive testing may work even late, but it will work less well the more it is delayed. You know, if you're very late, and especially if you cannot isolate people, maybe we're just chasing our tails. Perform rigorous epidemiological surveillance, representative samples of the population. Most countries have not done that. And I think that this is a pity because if you just wait for people to arrive and overburden ICUs, that's a bit late. The epidemic wave may have run its course even by that time. Employ information on risk distribution for precision shielding. Use epidemiology. We have been dealing with an epidemic without epidemiology. I'm very sad to say that, but epidemiology has been misused or not used during the epidemic. Protect hospitals and nursing homes, draconian hygiene and infection control measures, testing all personnel and residents regularly, more frequently in periods of resurgence and activity of the epidemic. Protect also with draconian measures about 5 to 10% of the population. Protect selectively other high-risk settings, for example, meat processing and other factories, prisons, homeless, and refugee shelters. Use standard measures that are known to work for the general population, not disruptive measures. So things like hand washing, of course, respiratory etiquette, of course, masks were appropriate, of course, non-disruptive distancing, of course. Disease of inequality, that's what we're dealing with. It's a disease of inequality and it's creating even more inequality. We need to protect the disadvantaged. You don't need to protect me, you need to protect people who need to be protected and have high risk and are at disadvantage. Hopefully vaccines will save lives and offer also some psychological immunity, meaning that we will be able to move on, but also be aware of the risk compensation problem and keep collecting data on hard outcomes, both for effectiveness and safety. Finally, we should not destroy our whole world with aggressive measures. I think that that's the worst that can happen. It is happening, unfortunately, in many places around the world, and that can be devastating, can be far more devastating than COVID-19, which is a very serious threat. We also have opportunities to have major gains during the pandemic. For example, every year we have about 8 million people dying from tobacco. In fact, half of the deaths with COVID-19 are probably tobacco-related deaths. People had underlying diseases that developed because of tobacco. So here's an opportunity. We have the opportunity to say, we have taken such serious measures. We have destroyed our economy. We have destroyed our society. We have destroyed our health to try to contain the pandemic. Well, why don't we ban the tobacco industry? Why don't we increase taxes for a couple of years in a transition plan and then completely ban it? No, there's going to be jobs lost. There's going to be some economic loss. No, really, actually, this will be a major gain in the short term and in the long term. And if we have decided that public health can make such bold moves as destroy society, economy, and health, it should have some bold moves to do things that really help rather than be disruptive. Many thanks to a number of my colleagues, both at Stanford and across the US and Europe and around the world, and in Australia and elsewhere, who have contributed to some of the work that I shared with you today. And many, many thanks to all of you for inviting me and for listening.
Well, thank you very much. I think we pretty agree with the way you are seeing things and putting on. Of course, I'm very, very suspicious about prediction based on model, and so far I've not been very deceived. But I predict that it will not work. But one thing that we find here that we just send out for publishing is we get the same ratio of reinfection that you get. So that's very low, that we get, I think, 32 for 7,000. But the difference is that we find that reinfection are more severe than primary infection, which is a huge question because we don't want that happens what happened in dengue, where immunization in case of reinfection result in more severe disease. And I think this is not clear to me, and we'll see what's happened. One thing that I think that modelization or epidemiology have not really think about deeply was that there is no one virus. There is several viruses. And the thing is that in Marseille, it was very difficult because we did what you say. So we test everybody. So we get thousands of tests. We've tested just in this institute something like 500,000 people. And then the first epidemic was a typical, bell curve epidemic. Quite, I hate to say that, but predictable. It's looked very much like all the epidemics that we have any winter with all the virus that we get. But what's happened if after a while, when we get 2 months without any care, when we open, and Marseille is very famous by having all the epidemics coming by boat, As long as there are boats, there have been epidemics in Marseille, coming from sometime from Greece or from Turkey, but and it happened exactly the same. So the boats come back from North Africa and then bring back people with a new variant. And then we identified that the variant come back from sub-Saharan Africa and then through North Africa and then to Marseille. And we find that because the first case come on the boat, really on the boat, like, bad in all history. And it was, but our approach as virologists was not a rebound. It was not a second wave. It was something else. And what we found, it was something else. It was a new variant. And this one lasts only for 1.5 months, don't kill anybody, and don't move through out of the area of Marseille. Okay. And then we get a new one who emerge that we call Marseille 4. The first one we call that Marseille 1. And this one is still running, and now it's going down, starting to be replaced with a mutation in 501 that includes, English one. We get the South African one because in Marseille we receive also people from Comoros, and the people from Comoros come back with the South African variant, so we get the South African variant growing on. So I think that one thing epidemiologically here is different, is that the people who work on this, some of the people who work on this don't even realize that there are different viruses doing different things, having different epidemiology, different curve, different targets. The ones that we get from North Africa infect much more young people than the other, with much lower severity. And then it's very hard to modelize. So the very last one, the English one, they get much less anosmia. We don't know why. It's a different virus, different clinically, different epidemiologically. And if you try to group the whole thing and make a story out of it, you can't do a single model for other things. So I think it's impossible. But I'm agreeing with you, we're wasting time in bothering all the people in spite of focusing on people who are, a huge fatality rate. But I don't know if it's because of the variant or because of whatever. We had in the first epidemic, we get in France, something like 28% fatality rate, and now we get a 14% fatality rate in the same. Also, the care have been very, very different and much better. We know much better how to treat this patient and how to care this patient. That make a very big difference. And this is also variable. So we learn when you get a new outbreak, you learn how to treat them. And after a while, you cannot modelize the fact that you have learned how to treat this patient. And this way it makes it different to predict. But I agree with you that most of these people are now immune and that there is very few chance that they get only probably very 1% of the people will be reinfected. So it will vanish this year, I think so. And I rarely predict anything, but I think it will vanish.
It's very hard to say, and I agree with every word that you said. It's a very complex situation. If you add the complexity of multiple variants replacing each other in the community. However, probably that's not uncommon. I mean, that's what you expect for a viral pandemic. And it's just that it's the first time in history that we're tracking that so intensely and so closely and, kind of minute by minute and day by day. Can we tell what it would look like a year from now? I mean, it's practically impossible, but at least we can make use of what we have learned. And regardless of how well we manage to contain the spread, avoid the vast majority of fatalities. If we avoid that, then it becomes more of a scientific curiosity. And I'm very eager to solve the scientific curiosity problems, but I really want to solve the public health, fatalities and major disruption problems, which I think are very acute, and we cannot really continue with them.
Yeah, I think maybe because I'm older or more, I become more pessimistic. I think that our society in Europe and America don't know to manage. There is too much. We're too old, and we get too much fear of everything, and then we cannot. When you get too much fear, you cannot manage properly. You panic. Politicians are panicking. They fight for stupid things, and the journalists are stupid. And the whole thing makes that. Oh, do you want to manage that carefully and say, well, look, we're going to try to see what's happened, really see the patient, try, we know now that we need anticoagulant and oxygen and so on. And why don't you work very, try to be calm, it's an outbreak, you need to fight with it and read this from Camus, it was very calm, trying to do the thing in the panic and try to do the thing. And this is, I'm afraid that our civilization are not able to do that anymore. When you see what's happened in Eastern Asia, I mean, they're very calm. They did it carefully.
Absolutely. I think that panic is the worst thing that has happened, and media has just made that a main theme, kind of propagating panic and terror and fear, and that's not the way to deal with it. As you say, East Asia went through the whole experience far more rationally and reasonably. Japan probably had several places in like Tokyo with very widespread of the infection. Nobody noticed practically. I'm painting a very extreme picture, but I think that all the panic and all the fear has made things much worse. Same thing for management of patients. You cannot really manage people with this disease just by getting them massively intubated and aggressively managed and throwing 20 medications at the same time to try to treat them. I mean, most of these people are very frail individuals. They would not be able to tolerate even more modest interventions. So I worry that there has been quite a bit of iatrogenic and also mediagenic disease in the course of the pandemic, unfortunately.
Yeah, the same. I had a lot of connection with Africa. Same, they were very calm and trying to manage the thing, and of course they get much less problem. And also because the old people are not in house just for old people, they are in the family and people who care about them, and that makes that old people don't die so with a high level like in countries like ours when you put the old people all together in house and with quite little care. But I think it's a partly a disease of our civilization that we have not been able to manage. That seems like that.
What do you think about early outpatient treatment?
Oh goodness. I think it's unclear to me how much we can achieve with early outpatient treatment. What I do believe is that we should avoid overcrowding hospitals. I think that somehow the response to the pandemic has been centered on hospitals. A lot of attention has fallen on how many ICU beds do we have and kind of like the end of the chain. And this is very unfortunate because this is a community infection. It needs to be managed in the community. We need to do our best to keep pretty much most of the management in the community and avoid hospitals being overwhelmed. I'm not sure that all the people who get admitted, we do really much for them. We have some options for treatment. It's very difficult to document how effective they are or how ineffective they are. As you realize, especially for early treatment, the outcomes are going to be pretty good in the vast majority of patients anyhow. So it's very difficult to substantiate this. There's huge polarization, there's huge debates, there's a lot of people who have nothing to do with science who have been talking about it. I know that Didier has suffered in that mix of journalism and politics and upheaval that has ensued. I just think that we should try to keep the infection away from hospitals as much as possible. And much of the time, there's nothing to do other than being calm and wait.
This is, for us, it's an important point because we found that early outpatient treatment can decrease by a threefold factor the deaths of patients, not only with antiviral, but also because of anticoagulant, because of kaliemia, because of all this. And so these have not been set up equally in all locations, not only in Western countries. And so this can have an impact, and this must be stratified by the risk of the population. Obviously, it's not the same benefit when you treat 20 years people and when you treat at-risk people. But,
absolutely, I think that since you need to take that risk stratification into account in whatever is being done. So I think we need more evidence for those who are at high risk based on their profile. As I said, the earlier the treatment, the least likely it is that you will have bad outcomes regardless of what you do or do not do. We have zillions of trials. As I mentioned, we have over 2,700 trials that are done or in the works or happening. Unfortunately, only a small fraction of them have been completed. I believe about 200 roughly have been published, or there's about 200 publications, which is like 6-7% of those that have been launched. So there's still a lot to learn, but I think that we should avoid overreacting and over-treatment. And the earlier the treatment, the higher the risk also of overreaction to to what we're facing. So we need some very solid data before I can tell you that, yes, clearly we know what to do in that case.
Well, in here, what we've done, as I told you, I think that we have treated something like 14,000 people, 11,000 as outpatient and 2,500 or something like this as inpatient. And our fatality rate was outpatient is 1 out to 1,000, 1 per 1,000, so it's quite low, a little bit less than this, I think. And in patients that come in fact, more late they come, and more high is the fatality rate. And even, and of course, it is, we are also getting better because we get these apparatus to make, high oxygen in people that were not able to go in critical care units because they are over 80. And with these people that were dying in 100% of the case, we saved 1/3 of these patients just by this, which the people who are older than 80 just by new apparatus of oxygenation. So by having these people, of course, we learn much, and we're doing better month after month. Fatality rate of the same people. But altogether, I agree with you, we have been not only in our institute, but in the all university hospitals, most years of all the people who died is around 3 years. And most, I say 90% of the people by using the Charleston classification have less than 1 year to live when they die. So this is very specific target, and of course we do what we can. But in this population, of course, the way to save them it's quite narrow.
I agree. I think that a very large share have very poor life expectancy. I've seen a number of analyses that have tried to model life expectancy, and I think that most of them are very poorly done because they explain a very small portion of the variance. If you only know about a few comorbidities and you don't know their severity and the overall setting of the patient, it's very difficult to make a good prediction. So most of these estimates that I have seen are probably inflated in terms of life expectancy and years lost. It's very difficult. I mean, for most of the people who die with COVID-19, there's very little that can be done. And, once you get to that advanced stage disease, dexamethasone probably works. So we have even randomized clinical trial data for that. It's very difficult to think of other interventions that have a very clear ability to save lives once you're at that late stage. For early stage, it's a different thing, but as I said, almost all these people do well anyhow. So it's very difficult to identify specific interventions with clear benefits in that population.
Well, one more thing that has nothing to do. As I told you, my son is a big promoter of your work in his new site, Peers, and I know that you have traduced your work on why the trials are always wrong. One thing that was really interesting in this outbreak is that, as I told you, I think that looking at the virus is important because it's my job. So I get a bias. I get a conflict of interest on virus. And of course, I think that the worst thing, I think the New England has been the worst journal in the world for this outbreak, the worst one. Because it published, a case where no diagnostic test was performed. In one study published in the New England, 70% of the people don't have a diagnostic test. This never happened in any time before. And the other thing is they don't control, which is what we know, that everybody is doing with AIDS or hepatitis C or whatever. They don't control how long does it take to virus disappear. You know, it's very easy to see if something works or not. You know, it's for example, I'm very interested because I haven't really been bothered by Gilead manipulation. But it's very easy. If you look, there's few people who get a chronic viral infection. And these people, so mainly people with lymphoma, they cannot control and they get the virus for long. And if you put remdesivir in these people, the virus stay for long. Don't care at all. That means it's not virucidal compound, not at all. And more than this, it's inducing mutation, specifically mutation in 501. So it's very interesting that people just forget it's a viral disease. So we need one of the points that you have beside, you know, doing statistic on the different, specifically when the population are not comparable, when you're mixing multi-center and then you get a terrible effects and you cannot control, then is the virus still there or not for us in virology is very important. And are you sure that the patient really gets the disease, so the diagnostic test is really important. And it's been really interesting. I've never been so disappointed by the flurry of publishing anything, you know, retracting a paper in 1 month and publishing a paper without any diagnostic test, any following, you know, it's terrible. I don't know what's happened. I think it's really disappointing. You know, I was so proud when I get Massachusetts give a lecture and then going to, you know, a meeting on the New England Journal of Medicine. And, you know, it's terrible what has been published by the journal. It's terrible. The same for the Lancet. So it's really impressive to see what happened with us. I mean, it's really impressive.
It's very unusual times, and I think that you know, these journals, they have amazing editorial boards, and you know, the reviewers are probably well intentioned, but it's very easy to get it wrong in the pandemic setting. I think that there's lots of scientists who try to do research very quickly. This means cutting corners, perhaps sometimes, and a lot of that work is very questionable. We estimate that there's about 200,000 papers that have been crafted on COVID-19 just within a year, practically. So there's lots of amazing work and a lot of really stellar scientists producing amazing work, but there's also lots of suboptimal work, and no journal can be perfect, especially under conditions of fear, sense of urgency, panic. You can very easily get it wrong. I mean, I'm not excluding myself. I'm part of the pandemic, and I'm sure that everyone's work can be wrong to some extent under such circumstances when you try to do your best, but there's a sense of urgency. And I think that when things become a little bit more calm, we will be able to take a look at what has happened and realize that there were major issues in the production, dissemination, and trust that we gave to a lot of evidence that was very weak.
Yeah, but I understand. I mean, I've seen that myself, but I'm surprised that very basic things, you know, seems to vanish immediately. So you make an infectious disease without diagnostic test, and you make series of these, and then you're discovering that, you know, for the Lancet, and even, you know, I've been editor-in-chief and associate editor in Medical Journal. You know, when you see the group of Mero publish this stupid thing in New England and Lancet, nobody can believe something like this. You know, it's just anybody who knows science cannot take a paper like that. I mean, it's stupid. Oh, could this happen? This is really, you know, everybody was mad there. What's happened? There is an epidemic of madness in the same time. I was looking, the only example that I have that look like that is this film with, I think it was from Spielberg, with Bellucci, on 1941. Have you seen this movie?
I think so. Yeah. Yeah. Mm-hmm.
Same star, you know. It looks like very much, you know, the New England to look like Belushi, you know.
Yeah. I mean, even under ideal circumstances, it's very easy to get it wrong. So, and under stressed, panic circumstances, it's even easier.
Well, thank you very much. It was an honor to get you here, and we are very impressed by your work and your calm in this situation, in contrast to many things.
A million thanks for the invitation, and I look forward to seeing you in Marseille or at Stanford in person.
So as soon as you can come, I mean, you're welcome. I would be really happy to invite you to see what we do and give another talk, of course. That was the cost to pay. But we're very happy. Where are you from originally in Greece? Are you from Greece or your parents?
So I was born in New York, but I grew up in Athens, and my parents were born in Athens also. Yeah, yeah. But I feel that Marseille is, you know, it's a Greek city. You know,
But it's not an Athens. It's a union. You know, it was built by Phocea, which is in Turkey. So it was union Greece, not Attica.
you know, those boats again, bringing viruses, but also building cities.
Okay, thank you very much.